we live now? Right, good morning and welcome to the Shropshire Health and Wellbeing Board. My name's Councillor Simon Jones. I'm chair of the board and I'm obliged to inform you that this meeting is being live streamed and recorded. Members of the public will be able to see this meeting and hear the audio. So in attendance, if we can go around the room, the attendees, what I would ask you, because it is being live streamed, when you are speaking during the meeting, if you can identify yourself. Okay, right, so if we go around the room.
Hi, I'm Rhys Robinson. I'm Executive Director of Health, Wellbeing and Prevention for Shropshire Council.
Good morning, it's Tanya Miles, Executive Director of People at Shropshire Council.
Good morning, I'm Arca, Director of Partnerships for Shropshire Health and Wellbeing CCG.
Good morning, everybody. Simon Whitehouse, Interim Chief Exec Designate for the Integrated Care Board across Shropshire Health and Wellbeing.
Hi, I'm Lynn Corley, Chief Officer at Health at Shropshire.
I'm Michelle Dolson, I'm Committee Officer for Shropshire Council.
Good morning, I'm Pauline Morrison, Assistant Director for Integration and Healthy Population in Shropshire Council.
Good morning, I'm Dr John Pepper, Chair of Shropshire Health and Wellbeing CCG.
Morning, Sam Tilley, Director of Urgent Care and Planning, Shropshire Health and Wellbeing CCG.
Good morning, I'm Sonia Roberts and I'm representative in Doncaster Assembly.
I'm Cecilia Motley, I'm the portfolio holder for Communities, Culture, Leisure, Tourism and Transport.
Hello, Penny Basin, Head of Joint Partnerships, Shropshire Council, Shropshire Health and Wellbeing CCG.
Hello, I'm Val Cross, Health and Wellbeing Strategic Manager, Shropshire Council.
Right, thank you. And I did omit to say that apart from being right, so that's in attendance. Apologies. We've had apologies from Patricia Davis, Shropshire Community Health Trust, Superintendent Stu Bill, West Mercia Police, David Crosby, Shropshire Partners in Care, and Sarah Ellis, RJAH. Are there any other apologies? Have we had an apology from Kirsty? Or
no.
Could just be traffic problems, because I understand she's attending. Okay. Sorry. Oh, right. Yes. We've got people online as well, so I nearly forgot you. If you'd like to now, as you appear, I haven't got, I can't read the screen.
If people just introduce themselves on people who are online.
Yeah.
They should be able to
Call them out, Val.
Oh, sorry.
Call that, yeah, because they're going to be, because otherwise they could all speak at the same time.
Okay. So. We've got people online as well. We've got Mark Brandreth. I can see we've got Alex Clevin, who'll be presenting a paper later. I can see Ben from MPFT and Laura Fisher from Shropshire Council. We've also got Toby Pierce, who'll be presenting a paper later. And I think that's it, but if you could message me if I've not mentioned your name and I'll make sure that you're recorded. Thank you.
Okay. Right, item 2 on the agenda is disclosable pecuniary interests. Members are reminded to disclose any pecuniary interests in any matters to be discussed which is not included on the register of interests and leave the meeting prior to the matter being discussed. Are there any such interests? No, right. Minutes of the last meeting. I won't go through them page by page. It's really just that people, they've all seen the minutes. Are we happy that they're a true and correct set of minutes, or are there any alterations? So I'll take it then that those minutes are correct and accept a true record, and I will sign them as such. Okay. Item 4 on the agenda is public question time. As far as I'm aware, there's no public questions as yet.
No.
Oh, right. Okay. Item 5 on the agenda is system update. Right, so we'll get, I think the first is Sam Tilley. Sam? Okay, Sam, so if you'd like to introduce your paper.
Thank you very much. So I've come today to talk to you about the UEC improvement plan for the current financial year. So I've prepared a short paper just setting out the context, but I'll just give a summary of that and then take you through the headlines of the plan. So we started off a new process in the previous year around improvements needed for urgent and emergency care. This plan builds on that previous plan and sets out a set of objectives and aims and deliverables for the coming financial year. So just to take you through the headlines of the plan. So you'll see in front of you now the process that we've used in terms of developing this plan. So as you might imagine, looking back in terms of what we've achieved, how the plan for the previous year worked, what worked well and what didn't. And then utilising that to develop our priorities, looking at data evidence, looking at some of the challenges that we've been faced with, and taking the views of our stakeholders in terms of developing a route forward. So we've pulled all of that together. We've looked also at the operational planning guidance produced by the NHS, which sets out some clear expectations around how urgent and emergency care will be developed over the coming year. In addition to that, we have worked, as I say, with our partners to take their feedback, to use the data that's available to us to develop our priorities. So you'll see within the plan that we've settled on 3 fairly distinct priorities around pre-hospital, hospital improvement and flow, and discharge. So what we've attempted to do this year is be very clear about a set of parameters that we want to focus on. I think what we found in previous years is, given the enormity of this agenda, given its prominence in terms of people accessing healthcare and some of the challenges that we face that I've set out in the paper, we wanted to make sure that we focused on priorities that we were going to be able to deliver, and we kept some containment around the agenda that enabled us to be really clear about what we wanted to achieve and that was deliverable. So on the basis of that, we've very firmly settled on 3 distinct areas of work. So you'll be aware that we have had a number of challenges within the urgent and emergency care pathway, some of which I believe have been discussed in prior health and wellbeing board meetings. The crafting of this plan is very much aligned to tackling some of those of the most prominent issues that we've been challenged with, and making some real improvements within the next financial year. So if I just focus on the pre-hospital slide, we might want to move the slides on a little bit.
Tell me which slide, Simon, I will.
Yeah, keep going. Next one. Yeah, that's it. Thank you. So you'll see here that we've got 3 distinct areas, as I've said, but there's also an acknowledgement that there are a range of linked programmes across the system that are being delivered that don't fall directly within the remit of urgent and emergency care, but are inevitably extremely important in enabling us to deliver what we need to. So there needs to be an interface with those programmes, and you'll see those on the right-hand side. Set out there, and we will be working in tandem with those programme leads in terms of delivery and that interdependency. But in terms of the main focus of the plan, as I said, we've got 3 distinct areas, and this slide just gives you a little bit more headline detail in terms of what those areas will focus on and aim to deliver improvements against. So in terms of the pre-hospital space, so this focuses, as you might imagine, on what happens before people get to the point of needing hospital care, hospital intervention. So how people interface with their with primary care, with 111, how they may arrive at hospital and the routes that they use to do that. And something there focused particularly on those users who enter the hospital and use those services frequently. You'll see from the bottom section of that green box that we're also looking at a particularly important piece of redesign around that pre-hospital pathway. So mopping up some of those improvement pieces that are noted above, bringing those together and saying what is it that we have at the moment around that pre-hospital space? Does it work for us? Does it produce the right outcomes? Is it connected in the right way? Can people use it easily? Does it provide the right outcomes? So that will be looking at things like our urgent treatment centres, our minor injuries units, our out of hours GP provision, how it all works together, and looking at the best way to provide that for our population. So a whole raft of things going on within that pre-hospital space. The hospital improvement piece focuses particularly on the activity that takes place within the hospital setting. So as people arrive, how they interface with ED, how they move through the hospital space, the hospital's discharge processes, so how we move people through that pathway. So you'll see there that there are particular elements around the estate. So there's plans around refurbishment of some of the areas of the hospital to enable us to use that space most effectively. Looking at the way that discharge works, have we got our processes right within the hospital? Are all the wards working to the same arrangements? Are we clear about the targets that we want to set in terms of moving people out of the hospital at the right time and enabling them to access the support they need out in the community? So a big piece of work around improvements within that specific setting. And then moving on to discharge, there's then a whole piece around when people move out of hospital into community settings. Does that work in the best way? Is the flow seamless and effective in terms of the time that takes? How can we improve on that part of the pathway, making sure that people have access to the most appropriate care for their needs, that we're not over prescribing that care, and that people can access that quickly. That area of work will very much focus on our interface with the local authority, with care homes and providers of care within the community. So a whole programme of work looking at the whole of the pathway, but being very distinct about the things that we'll focus on that we think will have the most benefit within the next 12 months. So this is a distinct part of a much longer term journey, but really focuses us in on what we can achieve within that time frame. So you'll see from the paper that there's a process of this going through approvals. So the Urgent and Emergency Care Board has approved this in principle as a set of priorities. We're now working up the detail. We had a very good discussion at the Urgent Care Delivery Group yesterday to work up the next level of detail around these plans, and that will go through the Urgent and Emergency Care Board at the end of May. We will then build very much a set of arrangements around how we monitor this, how we support this with data flow and communications to make sure that we're getting the best results from this. So that'll be monitored regularly throughout the year through those forums. So hopefully that gives a bit of a snapshot in terms of what is actually a really complex and pretty enormous piece of work. We've set ourselves some fairly hefty challenges, but also trying to be realistic about what we can deliver within the time scale. So I'll stop there. Hopefully that gives a flavour, and I'm very happy to take questions.
Thank you. Do we have any questions? Yeah, Rachel.
So I was just going to start by saying, firstly, Sam, thank you, because I think it is hugely complex, but I think the plan starts to lay out in a really in a very, very clear way There's clearly a lot more detail to come, and I think the board particularly will be obviously interested in understanding that detail and its role, and I guess in terms of the outcomes that we're trying to achieve around this, which is obviously that improved urgent care flow, that reduction in hospital waits, some of the challenges we've looked at as a board. At the last meeting particularly, we talked a lot around ambulance and response times, and I think that was a bit I just want to come back to. I think that's where we started from. We had a good discussion last meeting, particularly around ambulance response times. I think we very much felt as a board that obviously it was part of a much larger urgent care piece, which you very clearly presented. So I think it would be helpful, I think, for the public as well as ourselves to be very clear within this, if it's possible, about where that piece fits. It looks obviously in terms of the pre-hospital element, but it's not explicit. I don't know if it could be more explicit, because we'll want to understand, I guess, what will be the planning around that, what will be the actions, and how we feed into that. So I think there's just something around making that explicitly around this sort of ambulance element, something around seeing the detail of the whole plan, and perhaps bringing that back to a future board so we can have that. And just I think it is particularly clear. I think on the ambulance as well, just to land in that, it's not just about, in terms of outcomes, what we've seen this winter and the urgent care system, which has been a real pressure, but this has been a long running issue within Shropshire, particularly because of the rural nature, and it's how that can be captured within the plan as well. So just a few sort of observations and comments.
Come back on that. I'm very happy to bring back the next set of detail, and I think that it will be easier to see then how this tracks through in terms of some of the improvement areas, the particular KPIs and standards that we're trying to improve will be mapped into to the next level of detail around this, and how we then monitor that. And I think what is really important to just stress is that in terms of there's been lots of discussion about the ambulance piece, obviously, because that's been an area of particular concern. I think what's important to stress is how interconnected all of these elements are. So our firm belief is that by doing the things that we've set out in this plan, it will absolutely improve performance where we know it needs to be improved, particularly around some of those issues with ambulance delays. So while it would seem obvious that there's some elements of the pre-hospital piece, actually we need all of this to work better to enable us to make those improvements. So yes, further detail to come.
Sorry, just in response to that, sorry, in terms of being involved and working through that, I think there was a conversation that members of the board, many are already involved, but actually we'd be happy to bring in some of those kind of wider prevention voluntary sector elements that we discussed at the last meeting. So again, I think it's that offer, and that's part of the role of the board, and very happy to kind of support in that development.
Cecilia.
Thank you, Chairman. Yeah, this I think is heading in the right direction. I represent a very rural division in the south of the county. Some of my residents have great difficulty even getting to see the doctor just because of distance. And I think what's going to be a rather critical part of this whole thing is the fact that the client group needs to understand how they should behave, if you see what I mean. Because this is absolutely fine. If you're talking this through with professionals, that's absolutely great. But when it comes to how the patients should behave, if they feel that they're in need of care, I think we need to have some ideas about how we actually convey that, and convey it fairly simply. So it's probably we're not at that stage yet, I would suggest, but I do think it'll be a very important part of this, because then I think there will be a good chance that the general confusion that so often surrounds hospital admittance and treatment and discharge and everything else can actually be cleared a bit, and people can understand what it is, what the process is that they're going to go through. So if we can get onto that at some stage, when we've kind of got through the professional technical stuff, as it were, then I think that will be really important, and it will need to be probably conveyed out, you know, at the lowest levels, such as parish councils, that sort of thing, so that people actually really understand it, and then hopefully the whole system will work better. Thank you.
Thank you. Yes, Sonia.
Thank you. I'm going to sort of agree and disagree with Celia. I totally agree that we should involve the public, and I'd like to see co-design and co-production in anything that we develop, and I don't think it's too soon. I think the earlier we can involve the public, the better.
Tanya.
Thank you, Chair. So we've been involved with the plan and fully supportive of the plan, so thank you, Sarah, for this morning. There's a section, I guess, before the pre-hospital bit, which is around social prescribing and how we're supporting our population to be both physically and mentally well. So it's recognising that and the great work that goes on in our communities with the voluntary sector around how we support our people to remain well. So we don't even need to go bring up 111 or the other pathways. And then my other point is around discharge to assess model. So we are in full support of that model, fully embrace it. There is a risk to the model in that for the last 2 years it's been a fully funded model from central NHS and government. There is a risk in terms of how we move forward as a system. So we are having conversations as partners around that model and about future funding, but it is important to recognise the current position that we are in across the whole country in terms of discharge to assess model.
Okay. So do you want to come back?
I can do, yes. I mean, I absolutely agree with what Tanya's saying. We are very much working collaboratively around that piece. There is a risk. We have to work that through. It is complicated and it's going to be challenging in terms of how we move forward. But we're very much committed, I think, to doing that together and working that through. I don't think the answers are easy. We haven't got them yet, but those discussions are going on in terms of the best way that we can develop this for our residents, given the context that we're in.
Thank you. Lynn.
Thank you, Chair. So I'm Lynn Crawley from Healthwatch Shropshire. And obviously all of this is really important to us, but also is gathering the patient experience along the way as these things move forward. And at the moment we're planning to do a piece of work to try to gather the wider experience of ambulance services. And while we hear in the press that there are difficulties across that service, we also will expect to hear some positive comments from people as well. But we also hope to understand the challenges, particularly across the rural parts of Shropshire, and also ask people what they think could help while they are waiting, because as far as I can tell, there's not going to be any quick solution to those long waits. So it's about engaging with the population to get their views and their perspective on what could make a difference. The other thing I just wanted to pick up on was what was mentioned a moment ago about the public's attitudes and behaviour potentially. And what we at Healthwatch are keen to do is to help people understand how to use the NHS in its current form and as we move forward. And I think there is particularly a piece to be done about those communities of people who are relatively new to this area and even new to this country, who may have come from other countries, because I do think there's a huge education piece for people to understand how the NHS works and how to access it, not just for our local population, but for those people who've come from other parts of the world.
Thank you. Okay. Right, if there's no further questions, then Sam, thank you for your presentation, and then we'll then move on to next. And I've got the wrong screen up here. My screen has disappeared. What's the agenda? What's the agenda?
I think it's the ship report.
Sorry, ship report. Okay.
Okay, if I show the screen.
Yeah, right. Sorry, yeah, the Shropshire Integrated Place Partnership ship update. Penny.
Thank you. Thank you, Penny Basin, Head of Joint Partnerships. I'm just hoping that my screen will start sharing.
If not,
Okay. Apologies, it's just taking a minute and I need to rejoin the meeting.
I'll look for it in the meantime.
Sure. I think now that one is still sharing, and I'm not sure if it's going to allow me to share.
Yeah, I've unshared it, but it since I have taken it down, but it's
There we go.
there we go.
Great, thank you very much. So this is a follow-on update from the last Health and Wellbeing Board. We'll go into slideshow mode, makes it a bit bigger. There we go. Okay. So thank you. Around the Shropshire Integrated Place Partnership, which is a partnership of commissioners and providers working together across and voluntary and community sector, working across Shropshire to improve the work that we do, the health and wellbeing of people, and it is a subgroup of the Health and Wellbeing Board. As a reminder, I've just put this slide up to demonstrate that we have taken on board the Health and Wellbeing Board priorities, the priorities of the SHIP partnership, and that we're also focusing on community capacity and resilience of the voluntary sector, local care and personalisation, supporting the primary care networks, and integration in one public estate as areas of work for the board. Since the last time we spoke, we provided an update to the Health and Wellbeing Board. We have had a number of presentations and discussions around inequalities. So this is just to assure the board that this work is carrying on in earnest. We have the development of a health inequalities plan that is Shropshire focused, and then also working really closely with our NHS colleagues on an NHS, a broader system, STW, health inequalities plan, both working collaboratively, dovetailing so that they incorporate the important elements and are working together and not duplicating. The Shropshire plan is focused on the wider determinants of health, as you can imagine, thinking about all of the ways in which inequalities are understood and in our communities and what we can do about that across all of our services. We have specific projects underway, so we were happy to receive funding from NHS England to work in partnership with the voluntary sector to deliver cancer champions. So that work is underway at the moment. Cube and Lingan Davis are both delivering that for Shropshire, Telford and Wrekin. And also Shropshire through the Health Equity Partnership, we have a project going on in Oswestry, working with people who have co-occurring mental health and substance misuse issues. And of course, the Core 20+5 is something that we're getting very used to seeing, and it's really important for us as a system to think about, led by the NHS, and we want to make sure that we're focusing our care and are looking at inequalities of those people who are most deprived, also those with those particular health issues, particularly looking at mental illness, chronic respiratory disease, early cancer diagnosis, hypertension and case finding and maternity. And the +5 is looking at those clinical areas of health inequalities and really thinking about actually what is that for your local area. And for us, we've really considered those inequalities in our rural areas as the focus here. So that work is carrying on with SHIP. This is another key area of focus for SHIP, children and young people, and this has also been included in our joint commissioning reports as we're looking at it through a couple of lenses today. The key project areas that is coming out of this work is being led from our senior leaders across the area around Best Start in Life, so supporting those 1,001 days of children's lives, supporting schools and developing a whole school approach. It's an access triage social prescribing model. So what are those ways in which people need help? How are they able to find that help? Right from, is it through sort of accessing support online, right through to when you have a significant need, how are we helping people? So it's around making sure that people have access to that the full level of support as they need it. There's a particular project around stepping stones for looked after children in Shropshire that's taking form, and that's being done in a multi-agency way, which is really positive. And we're developing an integration pilot in the north of Shropshire that has a number of elements linked very much into the Shropshire plan, looking at how we can support families, children and families from right pre-birth right the way through, making linkages with maternity, making linkages with health nursing, making linkages with schools. We're developing a trauma-informed training package for the system so that the system understands what trauma is and really understands how to support people no matter what area they work from, how they're working with people or how their staff are working with people. We understand that there's a key element around workforce and training that we need to do as well, just pulling everyone together and working in the same way and not duplicating, and also producing significant needs assessments so that we really understand what are the needs of our young people. And provision is there. I won't read that out, but working collaboratively through a number of workshops with partners across the local authority with the voluntary sector will develop that vision. Another core area of work for SHIP is the local care. We talked about this quite a bit last time, so I won't go into a lot of detail. That's sort of reminding what the local care transformation programme is about, around that early intervention, around collaborating around, and really links into, as Sam said in her previous presentation, really links into that work around urgent and emergency care and joining the system up. Over the last year, there was a good implementation of our system-wide rapid response, and that's still kind of rolling out in certain areas of the county. The advanced care planning was implemented, and the system-wide respiratory phase 1 was implemented. Going forward, this slide highlights for all going forward what local care is looking at in the next 2 years. So that really focus on neighbourhood working, co-designing, aligning the integrated discharge team and place-based integrated care delivery, anticipatory care, so case management and risk stratification. I'm just pulling out a few, but they're there. And I think there's a co-design element to all of this that is the focus of the work. Shropshire, Telford and Wrekin community bed-based model is a key focus, and the senior clinical model for STW community bed provision, hubs and virtual ward, all being key areas of delivery over the next few years. This is just an update as well around personalisation and person-centred care, also included in the Joint Commissioning report, so I won't go into great detail, but just to assure the board that the work is moving forward really positively. So there's been the development or current development of an asthma app. So respiratory were outliers for respiratory for children and young people. So this is work taking action on that, working with our providers and also making things available for children and young people in community through creative health and different opportunities, community opportunities. And the same for mental health issues. So we know that children and young people in this area are struggling, in particular because of the pandemic, working closely with MPFT on co-production of what we can do to support young people when they're on a waiting list or when they haven't perhaps met the thresholds for that service, and how can we support people through their needs in a different community-based way. There's a project also on working with children on a dynamic support register, working with pods and packs. So that stands for Parenting Care Council in Shropshire, and pods, that's in Telford and Wrekin. Do you know, Sonia, the name? Sorry, I should know and I shouldn't use acronyms. And also just to let you know that personalised care is embedded within NHS contracting schedules for this year, which is really positive, because what it means is that it's a whole system approach to taking person-centred care, really focusing on shared decision making and the accredited training offers around person-centred care. Again, as we reported last time, involvement is a core part of SHIP, really understanding how we work with people, how we can gather that information, how we can co-produce. And again, just to finalise, just to say that areas that we want to bring back to the board in the future is the metrics, mental health and dementia, end of life, which will probably come in their own right in fairness, but also just to highlight that we would like to come back on the voluntary sector as well, the community and capacity building. And that is it. Thank you.
Thank you, Penny. Do we have any questions at all? Yes, sorry. It's not Claire.
Thank you, Chair. Parents Opening Doors is the acronym for POTS.
Thank you. Thank you. Thank you.
Thank you. Yes, Lynn.
Just following on from what Penny was saying, just to let this board know that last week Health Watch Shropshire ran our annual event, which with a focus on end of life, where we were able to launch the system end-of-life strategy, which was really helpful. So just drawing on that comment about end-of-life and enhanced health in care homes. So we also had a really great panel of speakers, including Derek from the hospice, people from SAP, the Community Trust, primary care, and also faith groups represented, so people could hear about the work that's currently being done about advanced care planning, including the work being done in care homes. Thank you.
Yeah, that was a very well attended. Can't think of the word I want, but anyway, it was very well attended. Right, yes.
So really helpful, Penny, to that. Thank you. I just want to reaffirm that Integrated Care Board absolute support for place-based working and the two place-based boards, and wanting to get into the space of that prevention and community engagement piece as much as the urgent care work and everything we've talked about. That's the clinical response to some of this versus the how do we work with communities differently and how do we really understand what's happening. So just wanted to take the opportunity, Chair, to reiterate the Integrated Care Board's absolute support and commitment to working at place.
Right, well, thank you for that, as I say, Penny, and the Health and Wellbeing Board sort of notes, accepts the presentation. Thank you. Moving now on to Joint Commissioning Board Better Care Fund, BCF. I've got it down as Laura.
Apologies, Chair, it's me again.
You again. You've got Laura's wig on today.
I do. Chair, unfortunately, Laura has to give her apologies today. So thank you, Chair. Penny Basin, Head of Joint Partnerships again. Board has been provided late, I'm sorry to add, Better Care Fund end of year report. So we were madly trying to pull together all the last minute bits and pieces that we need. And actually I have just been alerted just for the board's permission, so I will add an additional recommendation. That one of the metrics hasn't been finalised, and that's the emission avoidance, the metric that has been reported in the report. So we'll have to update that before we can sign it off finally. So the end of year report for the Better Care Fund is due on 27th of May. The board is asked to endorse it, but with that hanging metric, we'll have to ask for a proxy sign off, if that's okay, Chair. The recommendation would be that Tanya Miles, I was going to say Associate Director, I'm sorry I demoted you. Director of People, Executive Director of People would normally be the proxy sign-on for going forward. But just to go through very quickly the kind of key elements of the Better Care Fund final report for the year as part of the update. So we have, as we do fulfill our financial obligation around that from both the local authority and the CCG have done this year. And it's, as much as we were fearful, I think our metrics, although we have just missed the one metric by 0.4%, and the other metric we do have to finalise, but we have actually all met all the other metrics.
I was just going to ask, could you share your screen?
Well, sure, yeah.
The only reason I say that is I don't know if everybody's got is actually looking at the
report. Okay.
The report.
Yeah.
Although having said that, I presume everybody is actually.
Yeah, it was
yeah. Sorry, it was Sam. So.
I'll just share, and then everyone can see where I am on the report. Yeah.
Lovely. Thank you.
Rather than rambling on with no direction. So as we said, the report is the end of year report is due on the 27th of May. And the framework details for next year are yet to be released, but the report for this year does sort of provide a good example of what has gone on this last year, which is a mixed report. We've met most of our targets, hoping to meet the one that's hanging. I'm not sure yet about that one, but only marginally missing our 0.4 target on the discharge. It's 14-day length of stay discharge. It also asks for the report. I guess what's important to me is that the report asks for end of year feedback around how the Better Care Fund supports the system around integration. So we're able to positively report on that. And I think a lot of the work that you've heard about today is part of talking about that and the Better Care Fund as an enabler to a lot of those programs by providing that funding. We also provided an example about House to Home, which is one of our housing initiatives, really has supported people to remain independent in their own home, and that's contained in the report as well. And I guess they also ask in the end of your report what our greatest challenges are, and we continue to report, as I think we do, and given any opportunity, that our local context is our greatest challenge. So there's the financial element, but also our demographic and rural challenges. So it is more difficult to deliver services in a large and rural county, and we do have an ageing population, and these things make things more difficult, but our funding doesn't always allow us or make that easier for us. So additional, around the Joint Commissioning update, so additional areas that the Joint Commissioning Group are developing are listed in the report. The market sustainability and fair cost of funding policy paper is a focus for the group, and there'll be work on the market position statement going forward based on that as a key element of work going forward. So we do need to do a lot of work in our area around our market that's available to support us. It also highlights the children and young people in prevention and early help work, and that's what we just described in the SHIP as well, so I won't go into detail there. And again, it describes in detail the personalised care, which was also included in the last report. As always, the paper highlights the fact that we do, and it's been highlighted already this morning, that we do rely on grant funding to support our system flow, and without there lies in a risk for the system on a regular basis. Thank you, Chair.
Right, thank you, Penny. Are there any questions at all? Yes, Claire.
Firstly, I'd really like to thank Laura, Tyler and Penny for their work around the BCF paper and the joint commissioning work, because it's been phenomenal, and it was quite difficult because all the metrics actually changed quite quickly. So they really pulled it together, and it was approved nationally without any changes. So thank you to both of them for that. I think there's some work that we can really do that's linked to the place-based work as we start to develop it over the next 12 months around what is in the BCF and how that really supports the system to function and the place to deliver. And that's particularly around looking at how much non-recurrent funding ends up in the Better Care Fund, and actually how we get some recurrent funding in that to really deliver some positive changes for our population in place. So I think that's the piece of work that we need to look at going forward.
Any other? Sorry, yes, Simon.
Thank you, Councillor. So just to reiterate, I'm still relatively new to the system, but really positive to hear that the Better Care Fund was approved nationally. It would be remiss of us not to flag and highlight in the appendix, the variation in price in terms of the adult social care in the charts, and there, the expected year-end cost of 773 versus the actual cost of £920. So the impact that has on public spend and budgets, and the impact on local authority spend. So hard to read, but important that we see it and talk about this. And then just to build on Claire's point, 44 million pounds of public money delivered jointly between health and local authorities with partners has to be one of the vehicles that we use going forwards to drive the integration agenda, and being able to just make sure we can maximise how we can really tell the story of the difference this makes to local people in terms of how we use that taxpayers' money. And there's some bits in here which is really strong and powerful, and again, just want to make sure we build on that in 22-23.
Sorry, Rachel.
Yeah, thank you, Chair. I think just kind of aligned to that, and just picking up on the conversations from a few of the last papers again, I think just to highlight some of the work that's going on across the system, and obviously this board is kind of leading at a place level around prevention and inequalities, and we've talked for a long time about that shift towards prevention and sort of tackling some of the inequalities, and I think that's evident in all of the kind of the work that's going on, that the SHIP are overseeing that through the work through the Better Care Fund. But I think as we're I do think there's something about us bringing that together and making sure it threads through. So we talked about the urgent care that needs to be visible. There's an awful lot of work going on, and to make that really, really clear to this board, all of the work that's going on, because we actually need to do a lot more around that. But then that does link back, and since we're talking about funding, and unfortunately we're at that time already when we need to talk about funding, there is concerns around the funding that we invest in things like in prevention inequalities, that is often short-term funding, and that we do need to sort of start to see that shift, because we're not going to change anything unless we do start to see that shift. And again, that's one of our commitments as a board. So I think that it was just a theme that was coming out in the various papers, and I wanted to make sure we highlighted it. And I think we need to perhaps bring something more clearly back to the board just to join some of this up and show our commitment to moving that forward.
Okay, thank you. And we're asked to endorse the report, the Health and Wellbeing Report, so we're happy to endorse the report. And to approve the BCF year-end report 21-22.
Yeah. Thank you. And just with the final sign-off.
The final sign-off
because of the last metric, so it won't be altered other than that last metric.
And we're happy with that. Okay, thank you. Moving on to Healthy Lives update, which is Val.
Yeah, it's a paper for information, but I'll just very briefly, as we have a tiny window of time, I'll just quickly take you through this. This is a short report. Healthy Lives is the prevention programme of the Health and Wellbeing Board, and it used to bring reports prior to the pandemic, and in February we restarted, and we've had some really good meetings. It's a multi-agency meeting, and we have people coming in to talk about their link projects. So, for example, we had Ling and Davis in, we've had MEA, March of Energy Agency, who are actually part of the group now, came to talk and bring the work that they're doing, obviously with the cost of living crisis that's emerging. Very important that we link the work that's happening across partners with that. So the meetings are chaired by Bernie Lee, who's a consultant in public health in the council, and we meet monthly, and we met this week actually. So yeah, it's all about prevention, to keep stop people becoming ill in the first place, or help people manage their health condition and help stop getting it worse. And this is all about working together as a system. The Health and Wellbeing Board, the ICS, and SHIP, we do have many shared priorities, and the more we can work together, and Health and Lives is often this place for, not saying other places aren't innovative, but it's often this place to think, right, okay, you have these conversations, what can we do to move this on? And as you know, social prescribing was very much part of it, and still is, with a lot of that development work done through Healthy Lives over the last few years. So I've got a page which shows the governance structure, which I'm not going to take you through. I think it's quite visual, you can see what that is. So we discussed as a group particular areas that would come to the Healthy Life Steering Group to collaborate on. So obviously social prescribing, healthy weight and physical activity. We've got the upcoming healthy weight strategy, shaping places for healthier lives, which is the food poverty project, which Emily Fays has been before, and our partners at Shropshire Food Poverty Alliance presented at the board before. And then children and people, Penny talked about the trauma-informed approach with the SHIP presentation just before, and there's a lot of really good, exciting work happening with this. Mental health, which is suicide prevention for all age mental health as well, so it's not just suicide prevention, it's the whole mental health. We know there's a transformation plan happening, so just linking things together. The Health Inequalities Plan, and killed and seriously injured on roads. So yeah, really just what I said before, receiving presentations and reports to the group. So we do have a forward agenda plan to make sure that we're bringing things in that's related, and yeah, that's it really. I've got Marches Energy Agency, property, etc. And it's obviously programme management structure. So, like I said, the forward action plan, working action plan, forward agenda, sorry, working action plan, and I think that's it really. So happy to take any brief questions. It is very much where we're up to with Healthy Lives rather than exactly what's happening within the priorities. So you will have a more full report for the next meeting, I promise.
Okay, thank you, Val. Do we have any questions at all, Val? Yes, Tanya.
It was just a comment to make reference back to the UEC plan, that the Healthy Lives programme is very much that bit before the pre-hospital programme piece of work. About outcomes, I guess, Val, how do we kind of monitor impact and outcomes in terms of the Healthy Lives programme?
Yeah, we do have, I mean, the metrics are the metrics which are based within within the joint health and wellbeing strategy. But metrics is something we're going to look at in more detail at the next meeting, but also we want to make sure they're linked to the health inequalities plan and also the SHIP priorities. We want to make sure there's a matching across, because to avoid duplication and people having to do multiple reporting. So yes, the key ones are the health and wellbeing strategy.
Okay, if there's no further questions, the recommendation is that the Health and Wellbeing Board receive the update for information. We're happy to receive it. Okay, thank you. Moving on now to item 6, which is the Ophthalmology Transformation Programme. And have we got Barry? Yes, there we go. Okay, Barry.
Morning, everyone. I'm joined with the clinical lead on the programme as well, Claire Roberts. And are we able to share a presentation?
Yes.
Yes.
Yeah, Lucy, if you're able to share the slides, and we'll just talk through the programme.
Thank you, Barry. I'm going to take you through the slide. So if I could have the next slide, please, Lucy. Thank you. So in terms of the background to the Ophthalmology Transformation Programme, there are ambitions that have come from the NHS long-term plan around avoiding unnecessary face-to-face outpatient appointments. This has become a major issue following COVID and the work that's being done to restore services. We have got, in terms of local requirements, we need to identify ways to redesign and look at how we can make ophthalmology services really efficient in terms of future services and pathways. We have opportunities to transform and use virtual clinics, remote reviews and consultations, patient-initiated follow-ups, using advice and guidance with the digital technology, look at ways we can improve integrated working and really work on the role of community optometry in primary care. We've got challenges with COVID and backlogs and long waiting lists. We've got planning guidance and the requirements there around elective recovery. And in terms of our system sustainability, we've got a lot of elements there around recovery, workforce, where the clinical capacity sits, looking at outcomes and value for money. If I could have the next slide, please. So in terms of our case for change, we know, along with across the country, the need for eye care services is going to increase. We know, as already mentioned, we need to be thinking differently about the way that we deliver care and, reducing face-to-face outpatients where they're unnecessary. We need to be looking at early detection and prevention of sight loss. Really be looking at how we can join up services across primary care, secondary care and community care to make best use of the assets that we have in our area. We want to provide more services closer to home where we can, and there's lots of opportunities around new technologies and developments in eye care that we can take advantage of, and we need to use data more effectively. So if I can have the next slide, please. So in terms of our eye care programme, there are some key areas of work that we're including. So that includes referral processes. So that's referral processes, in the main from primary care through to community and secondary care. Looking at how we transform outpatient services, and really thinking through the integrated pathways and how we can make the best links and work that across primary care, community care, secondary care, and of course, not just staying with healthcare, but this is an area where we've got eye health and sight loss, and so for people who are living with sight loss, it's really important that we consider how the links are made with social care and voluntary sector. We'll also be looking at multi-speciality pathways where eye care is one element of that, but not necessarily the main elements. So there are some pathways, for example, some of the sort of like arthritis type pathways where there are eye problems, where it requires some thinking right across different specialities. We're not covering ophthalmology surgery or eye related cancer care because those are covered within different programs. And then I'm passing over to you, Barry.
Thanks, Claire. So the programme was scoped and planned late last year, and then it had to be paused, and we lost a couple of months over the core winter period between December and March, really, with all the kind of well-known pressures around staffing shortages, the outbreak of Omicron, and escalated operational pressures and winter pressures, which meant we didn't have the access to clinical and operational colleagues that we needed to be able to start the work. But the programme kicked off in earnest properly and started in February. So still kind of at the early stages, and it's set to run over a couple of years. But we're in that first phase of starting out engagement, a bit of a SWOT analysis to hear from providers, staff, people who currently work in eye care, and the patients and the public, and the independent sector providers, GPs and so on, about their experiences of eye care as it is currently in the county, and how it could be improved and what their thoughts and suggestions around that are, and then obviously consolidating that and taking that into the design and development work to help shape future improved eye care services. So the first round of engagement has just concluded, and then later in the year there'll be subsequent engagement, which is typical of a programme like this, really, to share back what we've started designing and coming up with, to get that further feedback and input, on the back of which we may need to finesse the models we've come up with, and then towards the end sharing back the final approved new model of eye care for the county, which is that sharing back of this is what we've done with what you told us. So between February and now, in terms of who we've been engaging with, is staff across the whole health and social care system, but predominantly staff as the kind of main ophthalmology provider in the county, staff who work in community and primary care settings, the independent sector eye care providers, patients and public, the local optical committee, and their in reach to that whole optometry community, GPs, NHS, EI, the general public I've already mentioned, Health Watch, MPs, local councillors, town and parish councillors, and the voluntary and community sector, through a range of different techniques and routes and approaches and workshops. Next slide, please, Lucy. So some of the completed activity, just to summarise, is some early insight work we undertook by going out to a number of community-based groups like the Telford Sight Loss Group and the WEM Macular Group. So kind of eye care related community-based groups we've been at to, plus some in-depth analysis of 3 years worth of eye care related complaints that had been received by PALS in the hospital and by the CCG. A review of Health Watch Insight with some eye care consultation already undertaken by Health Watch, so we factored their report and findings into our work as well. a public survey to which we had 262 responses across the county, attending local eye care clinics where members of the team went out and sat and spoke with individuals sat in those settings and those clinics, attending local groups, as I've mentioned, in person or joining some groups virtually. A public workshop and engagement session was held on the 9th of March. A clinical workshop for our current eye care providers and staff, clinical and operational, took place on the 31st of March, and then an engagement workshop with the independent sector providers was held on the 5th of April. There's also web pages on the CCG website. Currently includes the survey, the engagement plan presentation, the case for change, and then we'll add to that and keep kind of building on that as the programme develops and evolves. And we've put in place now a bespoke email address just for this programme of work to provide that other arm, that other opportunity for people to make contact and contribute and give feedback or ask questions. Next slide, please, Lucy. So that engagement work's just started. Where we are now, we've just undertaken the analysis, the thematic analysis of those complaints and the engagement outputs, and we've pulled those together and produced now a consolidated engagement report, which is about to be published and shared more widely. Identifying from that areas of focus and the recommendations and key themes based on the insight from that engagement work. And it was quite reassuring for us to see there was a lot of commonality in the kind of key 5-6 themes being said by the public were also being said by clinical colleagues and the independent sector providers as well as the areas they would like to focus on in terms of improving things. To share the report with the Eye Care Programme Board and Design Group, and which this is the point we're at now. It's about, we've just started, but the outputs and recommendations from that work is going to inform the design and development of future eye care services, models and pathways. So that design work has just commenced. The publishing of the engagement report and then updating wider stakeholders on next steps. We'll be producing monthly programme progress updates to stakeholders across the system, staff and the public, with monthly updates to the website as well, that will also be transitioning onto the new ICS website. Creating a couple of kind of vox pop videos that we'll have online of people describing the programme, what it's intending to do and achieve, and some of the benefits people can expect. A Q&A document for public and staff, some virtual face-to-face briefings for staff, clinicians and public, and they will continue throughout the life cycle of the programme. And then further engagement around autumn this year on the proposed kind of future eye care models that we've come up with. And I think that was it, unless there's another one, Lucy. So yeah, thank you. If there's any questions from anyone.
Do we have any questions at all? Oh, yes.
It wasn't a question just so much a comment. It's really helpful to have this thing brought through to the board to understand the process that's been gone through, and it sounds certainly very rigorous in terms of the engagement to be outlined. I think we're going to be asked to note the report, but I think it would be helpful if we could bring it back. I think you said about the autumn time you expect more proposals to be worked up, so we can just understand what those proposals are in a bit more detail and how that's the public being very supportive about each of the steps and what you're thinking. It would be helpful to understand a little bit more about that, possibly in the autumn. So I think that was probably my ask, that it would come back.
Yeah, absolutely. So if we bring it back in about 6 months with a bit more detail around the proposed future eye care models, that's great.
Right. I think one question from myself, and that is, are you able to give us any sort of details or update on paediatric ophthalmology? Because obviously that there's a situation with regards to that.
Well, children's eye care and paediatric ophthalmology is absolutely part of this programme, and we've literally only just started the design work. So I can't yet say what the future of children's eye care will look like, as we're still to do that design work. But to reassure you, that's absolutely part of what we're looking at.
Yeah.
But I don't think I'm able to comment on the current issue around SAF's provision of children's eye care, which is a different.
Yeah, because I am aware that it has actually stopped all new referrals, accepting any referrals, paediatric ophthalmology, because the specialist consultant has actually moved on, hasn't she?
Yeah.
Sorry, right. So with Rachel's comment. Oh, sorry. Yeah. Nigel. Sorry. Yeah.
Hello there. Good morning, all. I'm sorry I wasn't able to be there at the start. I think been speaking to Val. We've got a major incident exercise here at the Shrewsbury site, so apologies for that. Just on that very last point, then obviously working with Barry, Julie Garside and others, then we are looking at what the arrangements are going forward. Just in the immediate term, we have actually got a locum specialist paediatric ophthalmology consultant. So we've got measures in the meantime, but in terms of going forward, and I note that certainly in the ophthalmic surgery is out of scope in what Barry's just briefed, but that's obviously one of those elements. We're looking at arrangement of how we do a bit of joining forces with some of the neighbouring organisations on that, which, to be fair, we do with a number of other different services. If I may, though, Chair, I was just going to offer a couple of comments on this scheme of work, if that's okay, because I would really reinforce what Barry and colleagues have said. This is such a vital programme of work. I think we shouldn't underestimate just the volume of patients and obviously then associated families which this touches. Ophthalmology is a very, very high volume specialty, but it's easy to quote that without realising obviously the impact on people. So I'm really, and I know, Barry's mentioned it, our clinical teams and operational teams are really supportive of this bit of work. So the demand and the expected growth is significant. So this work is fabulous. I think the other bit is just to reinforce that point about it being multi-agency, multi-organisational. For all the right reasons. There's a lot of experts through the pathway, public sector, private sector, a super amount of patient groups and expert groups which also take part in this, and hence why that engagement piece is so valuable. I was lucky enough to do a similar piece of work in North Wales, working all the way from, as I say, primary care, optometry and others, but with those patient groups. And so I know SAF colleagues are firmly behind it, but this is a smashing multi-agency, multi-team approach, and I think it's super.
No, thank you. There's no actual recommendation on the report, but I suggest that Health and Wellbeing Board note the update, and that as Rachel has suggested, we have a further update in 6 months' time.
Brilliant. Thank you, everyone.
Thank you very much.
Thank you. Bye-bye.
Right, moving on to item 7 now, which is air quality. Kieran.
Toby Pierce.
Oh, it's Toby.
Yeah.
Is Toby online?
Toby's online, yeah.
Toby's online, right. Okay, Toby, over to you.
Hi there. I'm just hoping my presentation should load. Is that coming up now?
Yeah.
Is that visible?
Yeah.
Fantastic. Can you hear me okay?
Yes, thanks.
Fantastic. Okay, so I've been asked to give an update on air quality, and I've given a brief update report, which is you should have before you. But I'm also aware it's been quite a while since we presented to the Wellbeing Board, so I just wanted to situate it in context of the work that we're doing. So there's 3 general aspects to the air quality work that we're doing in Shropshire. There's the strategic work. So that's putting into relevant policies. You'll see a few listed here with LTP4, the taxi policy, the movement strategy and the local cycling and walking infrastructure plan, which is currently being developed. And likewise, we feed into planning, both active consultations on applications coming through, and we review those for the impact on air quality and potential impact on air quality. The key aspect that I'm going to cover today is the local air quality management work, which is our statutory monitoring and reporting to government, and I shall focus on that more shortly. And likewise, I was just going to stress that we still have our responsive work as well, where we're dealing with the queries from the public and other interested parties and specific concerns about air quality in the county. So the air quality, local air quality management work, there's a lot of acronyms here, please. So I shall try and detail those wherever possible, but they are all given in the report as well and highlighted. But that's our statutory work, and the key matters to be aware of here are that in Shropshire we have 2 air quality management areas. These are areas where the levels of pollutants exceed those in the UK guidelines. All air quality management areas must have a air quality action plan. That is a plan setting out how we look to reduce levels in that area and what specific measures can be done. And the key thing within Shropshire is that these were last reviewed in 2008. So our current focus is to get these up to date and redone now. So just to give you a brief idea of what we do, if you walk around our town centres in Shropshire, if you're looking closely, you might notice on the lampposts, we have a lot of these diffusion tubes across the county. That's how we monitor for nitrogen dioxide levels in particular. But we also have the other monitors you can see here, which are real-time earth sensor for monitors, and those help us monitor for particulates and other pollutants as well as they give live feedback to us on the levels of nitrogen dioxide. So just to put the current work in progress the current levels of pollution in context, we have 2 air quality management areas in Shrewsbury and in Bridgnorth. Both of these are situated in the town centres, and I shall have a map of those on the next slide. But just to give you an update from the most recent relevant data, obviously this was heavily impacted by the pandemic, with a large disruption to travel. That meant a substantial decrease in pollutants, which was a positive, but it's also quite helpful in setting out the nature of the challenge that we face to reduce pollution in these 2 key areas that we have declared in the county. So in 2019, the level in Shrewsbury was 52 micrograms per metre cubed within the Shrewsbury AQMA, and likewise in Bridgnorth 47, and the current UK standard is 40. So we're exceeding in both these levels, and that's an annual average across in these 2 areas. It's also worth noting that the current World Health Organization guideline values are coming down to 10, so that represents the scale of the challenge of where we hope to achieve in future years. With lockdown and the impacts in 2020, the data there was obviously severely disrupted, and the capture of the data as well, but the indications were that it only just came down to the annual average just below 40 with the entire lockdown measures in place. So it is a large challenge of how we're going to reduce these levels. So these are the 2 areas in particular. Shrewsbury Town Centre AQMA does cover the whole of the town centre, but the key area where we actually exceed the exceedances are around outside the train station and the traffic light junctions there. Likewise in Bridgnorth, the key AQMA area is on the Whitburn Street Junction and Pound Street Junction, which has a mini roundabout there, and likewise we have that's the entrance to the one-way system to the town. So it is really in Shropshire, our air quality is good in comparison to many other areas of the country because we are primarily a rural county, but in these 2 key areas we do have these exceedances on these kind of high throughput junctions. So the air quality action plan reviews, we'll be looking to undertake monitoring, which I've outlined here, establish the links to the key policy areas and strategies, establish a steering group with key stakeholder groups, and undertake the measure selection and impact assessment. So those key ones I've highlighted in red there are the work that we're doing at the moment. We've currently had agreed previously to commission the air quality action plan reviews externally. So work is currently underway to appoint a contractor. We've had tenders submitted just in the last week coming through, and these will be taken to our steering group for them to review and to commission the work. Likewise, to reduce the modelling of the current levels of pollution in these areas, what's influencing the pollution, what's causing it, and what therefore can be done to reduce pollution. We will be looking to, part of the air quality action plan review is to model certain different measures that can be undertaken. In order to identify these measures, we've got to understand what's going on currently. So that involves a lot of work with other projects and existing work being undertaken across the council, which I've got here. So we've got the local transport plan, climate change work and actual travel work being undertaken currently, public health with the new health and wellbeing strategy, the big town plan and other areas. So as part of the work, we're looking to review all of these existing policies, see and model the impact that these will have on these key areas, and then from there put that impact into our model, and that will help us recognise and highlight what work can be done to reduce pollution in these areas. That will then be formalised into the plan, which we will then be able to present both to council and ultimately to DEFRA, who we report to. So that's been a very whistle-stop tour of the work that we're currently undertaking. Like I said, the key work that we're doing in the most recent months has been around appointing an external contractor. There's only a couple of contractors who do this kind of specialist work and computer modelling that's required and that needs to be reported. Apologies, took me just going through to the recommendations that the paper presents. So I've given a bit of a broader overview of what's presented in the paper. The paper details details the more specific details around the air quality action plan review and the traffic data requirements that we've been facing. But the recommendations are that the board notes this air quality update and that there'll be a more significant follow-up report in September, and we're hoping to, depending on the contractor's availability, to have that work completed by then, or certainly well underway. Thank you.
Thank you, Toby, for the presentation. Do we have any questions at all for Toby on that presentation? Yes, Cecilia.
Not really a question. I just wanted to feed in to Toby. I was involved with Dan Wrench. I don't know if you know Dan.
Yes, I do. Yes.
Well, we were looking at this particular issue, particularly with regard to Shrewsbury and that high pollution area going on at the railway bridge around to the castle. One of the things that Dan was very keen on at the time, but we couldn't progress for lack of funds, was a green wall. And I just feed that in because that could be quite a useful solution when you get further down the road and are looking at options.
Yes, certainly. Thank you, Celia. That was certainly one of the measures that had been considered previously, and one that we may well be able to incorporate into the air quality action plan review. The idea with the review is to take certain measures such as this. I know that my previous colleague also mentioned exploring a lane closure, and there's other potential measures that can all be considered. And the emphasis that we hope to do with the modelling through the air quality action plan review is to bring forward some of these measures, map out and model what the impact of those measures would be, and then to select the most appropriate ones that would have the most biggest and effective impact, and to bring down the levels urgently. So yes, certainly all cards are on the table at the moment. That's part of the work at the moment, is doing this cross-working across the council with other departments to bring in these ideas, to bring in these measures, and to see which ones can be taken forward down the process of the review.
Thanks.
Thank you. And on that note, We're happy to sort of take the recommendation that the board notes the air quality update and follow-up report is brought to the Health and Wellbeing Board in September. All in agreement? Yeah. That's fine. Thank you very much. Moving on then to item 8, Health Watch Shropshire Crisis Mental Health Service for Children and Young People. Lynn, over to you.
A bit of a mouthful, isn't it? Firstly, I'd like to thank the board for the opportunity to bring this report to this meeting. And I have got a presentation and hopefully I'll be able to share it.
Yeah. You just let me know when you want me to move on then.
Thank you. That's great, thank you. So could you make it bigger?
Oh yes, yes.
That'd be helpful, thanks. So firstly, I'd just like to take this opportunity to thank the young people, parents, carers and professionals who shared their views and experiences with us as part of this report. Next slide, please. So just to explain that all age mental health has long been a priority of Health Watch. In fact, I think since we were established in 2013, but as you can imagine, this is one of the most hard to reach groups of our population, and it really highlights how much we rely on our partners across this system, in particular providers, when we're doing pieces of work like this to help us to promote it so that we get as many views as possible. The reason we did this piece of work was as a result of the CQC inspection at SAF and the report in February 2021, and we were actually asked by Hayley Flavel, the Director of Nursing, if both Health Watch Shropshire and Health Watch Telford and Wrekin could do a piece of work to try and get the voices of the children and young people themselves. And as she explained, she really wanted it to be a system piece of work. Next slide, please. So here, this was again as part of the context. We wanted to explore some of the detail around the quote here, where staff were saying that they were seeing an increase in need across the children and young people going into the trust. And also as part of this piece of work, we heard from schools. And here you see a quote from a head teacher who felt that they'd seen a significant increase in poor mental health of the children that they were working with. Next slide, please.
This is moving, it's taking time.
Yes, fine. Okay, so as part of our approach to this, because we particularly wanted to hear from the children and young people themselves, we actually asked both SAF and MPFT to forward our information to the young people experiencing crisis mental health services. Unfortunately, that got tied up in red tape, and I think had we been able to do that, it would have had an impact on the number of children and young people we heard from. But I just wanted to explain that that had happened. So instead, we had to use our usual methods of using a press release, poster and social media to reach out to children, their families and professionals. And that meant that we probably heard from people who may not have used crisis mental health services in this report. And so the diagram on the right just shows the number of people we heard from. And it's not surprising that across Shropshire, Telford and Wrekin, we heard mostly from parents and carers who had concerns about the children and young people that they were looking after. Next slide, please. So we heard about the experiences of children aged 10 and over, and we also interestingly heard from young people right up to the age of 21. And I know that when we produced this report, MPFT felt that there was some confusion amongst the population about which services they were actually using. And I think what that shows to me as the Chief Officer of Health Watch Shropshire is there needs to be better information for children and families about the services that they're using and how they all work together. And I would say that is particularly true for BU itself, because BU is a partnership of organisations working together. and it came from what people were telling us, that they didn't always know which part of the service they were accessing and how they were communicating with one another. Next slide, please. So this slide just really indicates the complexity of this issue, with the range of experiences and conditions that people were grappling with, and the impact that those were having on their mental health. Take a moment to just digest that. So a colleague of mine asked what's the pink and what's the green on that previous slide, and my reasoning was behind the pink being potentially conditions and the green being potential triggers for poor mental health. On this slide, we just wanted to indicate the range of services that people come into contact with when they're experiencing poor mental health. And obviously the pink squares indicate the inpatient services, but also a lot of the community services such as GPs, adoption teams, private counsellors, as we heard from a number of people who, due to long waiting times, had ended up going to private counsellors for support, but also schools themselves, who were telling us that it wasn't always clear to them how to get into services and what the referral criteria were, and that there was a general ask for that to be clearer for them. Next slide, please. So this is from one of the young people that we heard from, and it highlights an issue that came across in a large majority of the comments, and that was about waiting times to be seen. And this young person describes the impact on them of that waiting time, including increasing suicidal thoughts. But then they also describe the impact on them of seeing the psychologist and the psychiatrist, and how much it helped them and enabled them to go back into school and get a place of college. So you can see that when that service is there, that it really does have a big impact on children and young people. Next slide, please. So right through this piece of work, we were keen, at the request of Cathy Riley from NPFT, to understand what people felt could make a difference, particularly when experiencing a long wait for that specialist provision. And so this is what the children and young people told us. Obviously, they referenced the impact of waiting times on them, and also the fact that for many young people, it's important that they can see the same person, because they don't really want to have to talk about how they're feeling and what they're thinking to lots of different people. And also, as we go towards the bottom of that slide, that feeling that it's almost being expected that they will only get treatment when they're reaching crisis point. Next slide, please. So, as you can imagine, our report includes a lot of comments from parents and carers, and this slide just summarises the issues that they raise. As parents, they're holding those children as they wait for services, and so there was a lot of anxiety around access and waiting times. But also, when in the service, they were calling for better care planning and understanding what that care plan was, so that they could see how it was working, and also that personalisation that Penny referenced earlier about making sure that assessments are appropriate and those young people access the right parts of the service. Communication between the professionals and the young person, but also with parents. Again, that idea of being able to see the same person rather than lots of different people. How discharge is handled. Some people described that just being discharged from the service and not really understanding why that decision had been made. And there's a number of comments about the issues for people with autism in particular, accessing other mental health services, and feeling that they were separated out, so they were either receiving an autism service or a mental health service without much recognition that someone with autism might have wider mental health issues around anxiety and depression. Also, comments around the impact of the intervention, particularly if they felt it hadn't been helpful, and how that might have negatively impacted the mental health of the child and the young person even further. The impact of the pandemic, and in particular the lack of face-to-face appointments, which many of the young people needed and wanted, but also their parents felt that they found it very difficult to get that young person to engage with an online meeting or a phone call. I know that having worked with children and young people, phone calls can be very difficult, and it's really hard for them to speak out. Multi-agency working and signposting, so that was referenced in terms of communication again, but also the fact that parents wanted to know where they could go to if they couldn't have that immediate access to those specialist services, but also issues they had around the referral process itself, assessments and diagnosis, and often parents felt that the diagnosis either wasn't what they had expected, and that also came across from schools as well. Next slide, please. So here I've highlighted some of the positive comments we received, because of course, as we know at Healthwatch, there are a lot of people who have very positive experiences of our services across Shropshire, Telford and Wrekin. And many of these are about the person they actually ended up speaking to, about how kind they were and how well they listened. And so those relationships are really key to how people perceive the services that they receive. And also importantly, the comments we received as well about the GPs, who had been really supportive, as well as the schools who are helping families to cope. Next slide, please. So, as we did with the young people, we also asked for parents and carers to give us their ideas about what could make a difference. And so this included things like emotional workshops for children with autism or special needs, but also any post-diagnostic support for those young people to help them to come to terms with their condition and understand it, highlighting there that it is a really big deal. And also, a lot of parents understood that prescriptions are not always the right way to go, and that actually it's those talking therapies and other things that can make a difference. And also that idea that young people might be hard to engage with. I think that's also true for a lot of adults using mental health services, and that call for them to be, for people to work harder to engage with those individuals rather than discharging them. Next slide, please. So obviously a lot of it was about better access and better information for people, an increasing call for more face-to-face appointments. And I know that those appointments are available, but I think it's about them being available to everyone who wants them or needs them. A call for better care planning, and also some parents wanted the opportunity to share their experiences with other parents having the same challenges and issues. And also a planned transition between services, and that particular references either as you move between schools, but also through parts of the BU and adult mental health services. Next slide, please. So from the comments that we received, we identified a number of messages regarding what would make a difference to people experiencing mental health crisis. So obviously that is reduced waiting times, better signposting, and particularly for that support while you're waiting. Improved monitoring of children and young people in case they deteriorate during that wait, so that they can services can respond more quickly. clearer criteria of how people can access services or who can access each service, and that was called for by parents but also professionals, including schools. Next slide, please. Regarding communication, better communication, including to help manage expectations, because what we were hearing was that people were having to go back to their GPs to get, to try and push the referral forward, whereas a conversation with the provider might have helped them to understand the expected waiting time, or some idea at least. Efforts being made to try and help those children and young people be seen by the same person consistently. A reintroduction of face-to-face appointments wherever possible. Organisations working better together to help to manage and support these young people and their families, and more training for professionals so that they understand the challenges being experienced by these children and young people. And that some of that included autism awareness training, training around attachment and trauma. Next slide, please. As mentioned by the parents earlier, calls for post-diagnostic support, improved communication across the board, and better communication and partnership working during those transition periods. Thank you.
Thank you very much, Lynn, for a very detailed report there. Do we have any comments for Lynn? Yes, Kirsty.
Councillor Kirsty Hurst-Knight, Portfolio Holder for Children and Education. Yeah, and thank you, Lynn, for the detailed report. Really pleased to see on, I think it's page 3, that although the survey was time limited, you still continue to want to hear from young people. And thank you for the explanation about how little young people actually inputted into this, but parents and carers, and what you're going to do about that. I suppose I have a few points. The key messages, there's 11 detailed messages that you've put in the report. They're really interesting. And finally, in context, the 3 points there at the final page of the report. What next? What do we do? How do we move forward on this? How do we help the young people that we know need help and continue to need help and support in Shropshire? That's not an easy question to answer. I know it's a big conversation, but this has really given us food for thought, this report, Lynn, so I really welcome it. What do we do now to make change? How are we effectively working? We have started partnership working, but where are we going with this? And finally, Health and Wellbeing Board, I suppose, when do we next get the update on this report? Where are we going with it? And how do we use this information to move forward? Thank you.
Simon.
There's a risk in following the council in terms of that I try and answer the questions, and my intention isn't to answer the questions, but I think those questions are really important, councillor. So look, the first bit is, I think the report was difficult to read, but difficult to read because of the messages that pull out, and that's because of how that was written and pulled together, so thank you for that. And I think I'm going to do a couple of things. I think there is a request to Claire in terms of from a commissioning side to pick this up through the children and young people's conversations and through the mental health conversations, because those 11 points we need to build into the conversations we're having with our providers. I'd like to do that in partnership with local authority colleagues, so we do this from an education point, not just from a health provision point. How do we do it from a best start in life approach? The second bit would be, and this might be a step too far, what's the opportunity for the 2 health and wellbeing boards to be the sponsors of this report, given the report was done by both health watches, and almost hold us as a system, a wider system, to account in terms of what are we doing to implement these 11 pieces, because the report was done by both health watches. So let's build on that momentum. And then the final bit is, this needs to be front and centre of the reports that keep coming back, in terms of whether that be through the Integrated Care Board or through the Integrated Care Partnership or through the two Health and Wellbeing Boards. But we need to make sure we've got one place, and if that's the two Health and Wellbeing Boards jointly leading out holding and leading the system, and partners within it to say what are we doing to better improve the situation for our young people, then I think that has to be one of our priorities.
Thank you. Yeah, I've got Ben, who's online, and then I forgot the person, John, and then Penny.
Thank you, Chair, and thank you, Lynn, for the report. Obviously, some really powerful messages in there, and things which are sort of consistent with previous work undertaken, just highlighting the many challenges that we have. Just to note, really, a couple of things. One is there is work ongoing, isn't there, on a children's commissioning plan, and I think clearly that's pretty central to systematically picking up these issues. These are sort of whole system issues, really, and something require a lot of collaboration. And I believe, Lynn, that Kathy Riley's reached out to you and asked for some additional help to make sure that children and young people's voices are sort of very central to that piece of work, as I understand it. And you know, we know that we didn't get perhaps the number of children and young people's voices in that report. We understand there's some challenges around IG, and obviously would be supportive of trying to kind of address that into the future and feed that into that commissioning plan, essentially. And that's it, really. So just to kind of note those things, please, Chair.
Yeah, thank you, Ben. Lynn, did you want to come back on that?
Yes, thanks, Ben. Both Healthwatch, I've been making a conversation with Kathy Riley from MPFT, which is very helpful, and she was very supportive of us doing this piece of work. And I have discussed with her the challenges that we had in reaching out to the children, young people themselves. And as I mentioned right at the beginning, this goes much beyond this piece of work, actually. Whenever we're doing a piece of work where people are asking us to speak to specific parts of our population, we really need the providers to support us to do that, because we don't need their contact details. You have them, we just need them to receive the message. And yes, Kathy has asked us to do follow-up pieces of work around this, and so we're hoping to do more work. Our plan was never to start at crisis with working with children and young people. We always wanted to start at that lower, general health and well-being end of this picture, so we could start talking to children and young people about the sort of information, support and advice that they want to receive as they get older. Because for me as well, I'm really keen to sort of demedicalise a lot of issues around mental health, particularly with children and young people, and help them understand that normal anxiety and even sadness is something to be expected, and it doesn't mean there's something wrong with you. And so to build on resilience and things like that going forward. So yeah, as Healthwatch, we're keen to hear more, and as I say, we're keen to hear that much wider view from children and young people.
Thank you, John.
Thank you, Chair. And just really wanted to thank Lynn and Healthwatch for the work in this. It really pulls out the importance of feedback. I mean, this is goes without saying the huge importance of the mental health care for children and young people. But gaining the feedback, gaining the voices, this is the way we can then respond and shape services properly. Hearing what matters to people. Some of the themes coming out: continuity, timeliness of responses being listened to. I agree with Simon. It's a very difficult read, and hearing the poor experiences is difficult. And there are also positive experiences there too. But I think the report, the strengths within the report is you also listen to service providers as well, and as people have said, this does cover so many areas of our structures, schools, general practice, social services, specialist providers, inpatients, and it's heartening to see, that the will and the collaborative approach to solving some of these issues. I mean, within the report, some of the responses, make reference to the implementation of crisis teams for young people before entering a hospital environment or after discharge, the in-reach work that's been done now between community mental health services and the hospital, the push for really to try and encourage region and at a national level for the provision of tier 4 beds, which we know there are difficulties with, and clearly the future has significant financial challenges to deliver the services we need. But I think, Lynn, just to commend the report and the fact that you highlight that this is the good mental health care for children and young people is throughout our society, and not just in a secondary care environment, and that's how we improve the future mental health care of our children and their mental health and well-being. So yeah, thank you. And the final thing really was to say that feedback isn't a moment in time, it's a continuum, and we should keep listening to these experiences, lived experiences of our services. So thanks.
Sorry, Lynn, yeah.
Sorry, I wasn't sure what the music was, but I was slightly distracted. Yeah, I just wanted to just draw people's attention to the final few pages of that report, because that is where the Commissioner and the providers have responded to the feedback. And that is really important to us as Health Watch, because it's an important way to help communicate with those young people and their families about the work that is being done, because we know as Health Watch that there's a lot of work being done, and so it's important for us to give that information back to the public, but it will also mean that we will need to follow up some of those things talked about in those responses to see if they're happening and the impact that they're having.
Right, we've got Penny and then Claire.
Thanks, Chair. And yeah, thanks, Lynn. I think it was really helpful for everyone to see that in writing and on the screen. I just wanted to draw the attention to and Lynn, you're part of that work where we're looking at the other ways in which we're engaging with young people. So as part of the Health and Wellbeing Board strategy development, we've been working with SYA to talk to children through schools about the things that concern them, and we've also connected that to the creative health work that I described in the SHIP report. So that work is sort of coming together so that we can look at the feedback that Health Watch has received and will continue to receive, but also that work done by SYA and others who are engaging with young people. So we can kind of look at it in the round and see, because for example, with the work that SYA are doing, they're continuing to engage with young people who put their hand up and said, we want to work with you, which has been quite a few young people in some schools. And that's quite helpful for us too, because we can then take to them particular issues. Are you interested in working on a piece of work around asthma or mental health? And get that kind of continuous feedback from them. And I guess just to reiterate that it is informing us in the work that we do around the creative health offer and the children and young people social prescribing. So we're also getting feedback through the children and young people social prescribing programme on what's working within the programme. What do children and young people think a personal care and support plan should look like? How is that going to support them? And some really positive things there. So I guess the reason I want to highlight that is to say there are a number of things happening in the system already around kind of, Kirsty, you were asking what are we doing about it, and we need to do a lot more. And I think what we often do, because we struggle financially, is sort of trial something out and see if we can grow it. And I suppose we're at a point now where we've tried a few things and we really need to grow it now. So we need that kind of the board that Claire chairs and others to kind of work with what we've tried and what we need to do to see how we can build those further. So I think that's so yeah, just the plea to say we're not starting from scratch. There are things happening. We need to kind of build on those. That is it. Thanks.
Claire.
I never know where to start with children and young people because it's everybody knows in this room it's a real big kind of soapbox thing for me. If we don't get things right for our children and young people, we will continue to fail both in health, education and social care. So we have to get this right. So again, thanks to Lynn and Health Watch for producing that report. We'll certainly take those actions forward, but actually I think we need to kind of step back before that. For me, it's about that children's voices, and we know that the project around maternity voices has worked really well in gathering that view of mums and mums to be about what services should look like. And I think we could start and do that and join up some of the pieces around the children's voices that we have, both through schools, early learning, universal settings, our providers and our kids that are accessing some of our mental health services as well. We need to get to a point where we're doing that preventative health and wellbeing work so that kids aren't going into crisis. Wouldn't it be lovely if we didn't need tier 4 beds, because the preventative services and the support that we've got for families, parents and kids enabled us to stop them having to need a bed, and that we could support them in that way. So saying all that, that's the principles off the back of the Children and Young People's partnership work that we're starting to deliver. So I also chair the Learning Disability and Autism System Group as well. So we're looking at that from a potential of SEND children coming through, and have lots of conversations with Kirsty about this. So making sure that it's inclusive, that we hear all of those children's voices, and we're developing and design services in a co-produced way that's genuinely co-produced with children and their families. So that's the principle. The challenge is we have, not just financial, are around workforce particularly, because it's really hard to read that children see different people that they have to repeat their story to. But unfortunately, people leave jobs, they get promotions, they don't come and work in Shropshire, and we need to address that challenge, and we need to look at the model of workforce in a different way that is really supportive. And we need to have a seamless transition into the services that we've got, whether that's early in universal services or into crisis, so that it's seamless and children and families aren't passed from one part of the service to another. So those are some of the key things that we're talking about. On the positive side, we have done a gap analysis. We have started to look at where the demand is outstripping the delivery of those services and how we might manage that better. And we're also doing quite a lot of work around autism, so raising awareness, the Autism in Schools programme, and some training. So there are some little shoots appearing, but there's much more work to do.
Thank you, Claire. Tanya, we wanted to.
Thank you, Chair. So thank you to all board members. It's great to have a conversation around CYP and mental health and put it on the same parity as we often do with physical health. So I think it's been a really great conversation. So thank you, Lynn, for bringing the report to us today. And as Simon said, a really difficult and painful read, and I guess one that doesn't come as a surprise to us as board members, because we do hear this on a daily basis from young people and families in Shropshire. And I guess the key bit now is that our young people in fact want to hear what next, what's going to be different. So the 11 points that are raised in the report, it's really important that we actually feed back to the wider community. We've got the SHIP board meeting this afternoon, and Lynn is coming along. She will test me to make sure I've listened to this morning's presentation, I'm sure. But I know that my SHIP board members will also want to know what's next, what we're going to do different in Shropshire. I want to put on record my disappointment that our partners were not able to provide Health Watch with the information or to support in getting a wider feedback from our children and young people, because they do have that information. and it's quite a small cohort that Lynn's been able to speak to. So I think the next round that we do this, we need to learn from this and make sure that we do reach out to all children and young people who have or are receiving a service from mental health services. Thank you.
Oh.
Thank you. Yeah, really powerful presentation and the discussion today. And I guess for me, there's something about placing all of this work in the context of the wider family unit. I think you mentioned the impact on parents, particularly, and really want to hear more about their voices, their experiences, and what we could do from a preventative and early help offer to them to support them, particularly when a child is in crisis. I guess the other group that I'm really mindful of are any siblings in the family home and those children and young people that might be impacted, by what they're seeing, what they're hearing, what they're feeling. And I think as your work develops, how we could perhaps support in terms of accessing that wider family unit and siblings particularly, I think it would be really powerful to also add their voices to this conversation, discussion, and for us to think about how we can support them better and moving forward too.
Thank you. Right, well, we've had a good discussion on that, and as everybody's commented, Lynn, very good report. There's no recommendation, but we're obviously sort of note the report and update. And Simon, you'd mentioned about you made a proposition that health and wellbeing boards actually. Sorry, I'm faltering now. What was your actual?
So it's whether both health. Sorry, Chair. It's whether both health and wellbeing boards almost acted as the overarching sponsor on this, because it was across Shropshire Health and Wickham, and so whether it be something that actually we could look at how we might do something differently with those 11, because I think it's Tanya's point of so what, and how do we keep a focus on that, and it's whether the two health and wellbeing boards, because I'm assuming this is going to the Telford and health and wellbeing board as well.
I believe it's already gone to Telford Health and Wellbeing.
So might there be something where we can, rather than repeating or duplicating conversations, actually we could do something where for this we have an oversight and we have a sponsor. I'm new, Chair, so I might be throwing a bit of a curveball.
Yeah, Rachel.
Yeah, so that's certainly a conversation we can pick up with our colleagues in Telford. I think there's some aspects of this that will be place-based, but there will be, obviously, I think you're absolutely right, this is an issue. But I mean, from a scrutiny point of view, I know it's something that our scrutiny are interested in and want to ensure that we and hold us all to account to make sure that we're doing the actions that are within the report. But I think you're absolutely right in terms of that joint health and wellbeing board conversation. We can pick that up.
Sorry.
No.
So I would agree, and taking it into place for the focus on delivery, and then it's that sponsor and oversight to say, is that then happening, and how can we see the difference that we're making to the children and young people that we're responsible to across our geography.
Claire.
There is a children and young people system partnership board. So, we don't meet for meeting's sake because there's an operational board that sits underneath it. But that was the board that set up the gap analysis. So what I would suggest, because that covers Shropshire Health and Wrecon, and all sort of professionals, health, social care, education, I would suggest we convene a partnership board and take this particular work, and then we can decide how those recommendations from the report are taken forward and reported on the delivery through the place-based boards.
And then I think if we bring that back through to the joint with the members in the scrutiny angle, I think we can tie that off. So.
Okay. Thank you. Believe it or not, I was given 10 minutes on the programme to discuss for this the presentation and the discussion. So we're running a little over time now, but it's been a really useful conversation. This. So with that suggestion of the partnership board, we're happy to commend and accept the report. Yeah, thank you. Right, getting back on to item 9, JSNA update. Rachel.
Thank you very much. Thank you, Chair. I'll try and make back some time on this. So I'm going to just talk very briefly through the report which you've all had. Alex is online to come in and answer any of the more technical questions and probably to correct me if I go astray. So obviously the Joint Strategic Needs Assessment is one of our statutory requirements of our Health and Wellbeing Board. We have been bringing regular reports through to the board, but we haven't had this for some time. So we just wanted to give you a brief update on the work that's been happening, particularly through as we've been delivering Omicron and others where some of the work around place-based needs assessment had been paused. So firstly to say that we asked about 18 months ago, actually it's 2 years isn't it, since we went into COVID, 2 years ago we set ourselves a particular programme of work. One was that we would deliver a SEND needs assessment. That I'm pleased to say is now being delivered. And that did involve co-production, and that took some time to bring that together, but that is now being completed. The second piece of work, which is a piece of work again that sits statutorily with this board, is a pharmacy needs assessment. Colleagues will be pleased to know that we're working across Shropshire, Telford and Wrekin on this, but we have to deliver 2 separate needs assessments, primarily for NHS England, and we smile about this. It's an interesting anomaly of the Health and Social Care Act, but so work is progressing to deliver that, and we are working forward. There's surveys gone out across our practices, and as you will know, it takes a significant amount of time actually to write the Joint Strategic Needs Assessment, the pharmacy needs assessment. So we expect to bring an update through to the board in the autumn. But just to give you the board reassurance that work is in progress and is moving forward. The other big aspect of the work that we said we would lead on is we agreed a place-based approach to Joint Strategic Needs Assessments. And we were starting, if you remember, there was 2 elements to that. One was a web-based tool that we were starting to pull together some of our core data sets. That would be some of the underpinning data across not just health and care, but across the wider determinants of health, which, as we've agreed as a board, is so important to understanding our health and impact on our health and well-being. So that piece of work you'll see, there's a slide pack, I won't go through it, that just shows you that starting to be visualised. There's a lot of work to do around that, but it's starting to visualise some of the data that we hold, looking at data, as I said, around some of those wider terms of health, as well as our geography and demography as well. So, and that will be really important, not only for Shropshire, but it will be important across our, as we take the population health management across the system. So that has slowed down because of the pandemic, but the work has restarted on that web-based tool, and that, an example of that is the impact. The other piece of work, you remember, we said we do this place-based needs assessment. We'd start with the 3 waves. We'd start with wave 1, and we'd start with 3 areas in that wave. The first being highly, and we were then looking at Oswestry. That got paused because of Omicron, and I think, but we are restarting that. We've got a conversation tomorrow to restart that engagement process in highly. So this is not just about understanding the data, it's understanding what our local population, that kind of co-production, working with colleagues in the voluntary sector, with Health Watch, with our town and parish councils to understand the issues in the area of opportunities, the assets, and bring that together to really understand the health needs of our population. So just to give the board assurance that we're restarting so that process again, there's a number of areas. And then alongside those needs assessments, you've heard already today that we're planning to do children and people's needs assessment. We also need to look at drug and alcohol needs assessment, again, another important area of work. And there's some significant work that Alex and the team are also doing that again support board priorities, particularly there's a huge amount of work around inequalities, supporting our primary care networks and their inequalities agendas. And as you would expect, we are working not only within Shropshire, but we work across the system in our population health management approach. And I know Sam's had to leave, but Sam obviously and Craig are instrumental in some of that work. So I wasn't planning to go into huge detail, if that's okay, Chair. I'll bring in Alex if he wants to add anything, but it was just to give the board an update and to assure the board that progress is being made. To apologise for the delay, but I think we all understand the delay and how we're trying to move that forward at pace, because again, this is an absolutely core pillar of us understanding the needs of our populations and also monitoring impact, which we've also talked about. So I'll leave it there, and I don't know if Alex wants to add anything, or over to
Alex, do you want to add anything?
Just very, very briefly, I hope you can all hear me okay. Yeah. Just very, very briefly, hopefully I think between about pages 95 and 100 of your accompanying papers, there's some screen grabs of that web-based tool that Rachel mentioned there. Hopefully that will give a sense of kind of the visual style, which is basically being designed to allow users to draw out those key messages at a high level, but also many of the elements that you see in there when they'll be on screen in that case when they're on screen, they'll be clickable and allow people to go beyond sort of those higher level observations, look under the bonnet, if you like, be more specific around specific measures or groups that they may be interested in, and they want to interrogate, and download the visualizations and potentially download the data, taking into account information governance and those sorts of things. So that facilitates kind of putting together strategic documents across the system, funding bids, and people can actually discern themselves and get the maximum value out of the data that might not be possible with sort of a conventional document, while still having that functionality to download and distribute the reports, for example, in PDF format. So, yeah.
Great, thank you. Any comments or questions? Yes, Simon.
Only one quick comment, Chair. So I think this is really helpful, and at risk of the JSA is always in the past having been in other areas something that is produced and comes once a year and then sits on a file somewhere versus something that you can go in and access and we can get people to use and become interactive, and how we start to plan and think about our service development and genuinely doing something like the health inequalities that COVID shone the light on, that we knew existed before but we never got in and tackling, then I think this enables us to get into that space in a fundamentally different way. So really positive. And then one final bit, there was no key points in the ethnicity bit. I just wondered if that was just when the screen grab was taken, because I found the key points really helpful to then look at the page, but there was nothing in the ethnicity box.
Yeah, it's very much a work in progress at the moment, so which is the point we've got to. I think by the next board, we're hoping that we can be able to show you perhaps even on screen a bit more interactive with some of that work that's taking place. So again, board needs to hold us to account absolutely on making sure we bring that to you.
Okay. Right, so we've got a note here to note the update work programme and timescales. Happy to note? Yeah. Okay, thank you very much. Moving on to item 10, which is the health protection update, including COVID-19. Rachel.
We've also got Sue here as well.
And Sue, sorry, yeah, Sue.
So I'm not going to say very much. I'm only going to introduce it to Sue. I mean, you'll know, the board will know for the last 2 years that we very much brought COVID updates and time updates to the board. We obviously have moved into a new phase of living with COVID. We are obviously still monitoring that, but we, as part of the board's assurance process, we want to bring you regular updates on health protection. And this is our first attempt to try and bring that more widely, but obviously we certainly won't forget COVID, and we're obviously keeping a close eye on that. And so I'll hand over to Sue to go through the report.
Okay.
Thank you, Rachel. Thank you, Chair. So, as Rachel says, this is the first board report, and it is for noting. So the report will cover the areas of health protection that we cover as a council and the responsibility of the director. That includes immunisation, screening, communicable disease, waterborne disease and foodborne disease. The situation in Shropshire at the moment, I will highlight areas of particular interest. You can see that our influenza cover is good. Our child immunisation programme status is good, but there are patchy areas, particularly the areas of inequalities, where we do need to focus more attention. So we are picking those up. Much of this work is done in partnership, obviously, with our NHSE colleagues, our NHS colleagues, and our UK HSA colleagues. Our school-age vaccination programme currently lower than expected in terms of uptake. However, this is a knock-on effect of the pandemic, and there is a programme in place in order to catch up, and that will be with our schools services, and the full data will be available in August. One area of particular interest is shingles cover. Now, shingles vaccinations are available to our population aged 70 to 79 years old. Very protective and preventative, clearly. However, our uptake is lower than the expected 60%, so we have an opportunity there potentially to link with partners who are working with the older age group in order to encourage further uptake through GP services. Pertussis vaccination in pregnancy. We are achieving that, though there is a programme going forward which is proposed to be joint COVID and pertussis vaccination, and we're waiting for GCVI, which is the National Advisory Board advice on that. Screening uptake, our antenatal and newborn uptake is good, but our cervical screening is lower than expected, particularly in younger age groups. Again, our NHS England colleagues are working with local practice facilitators in GP practice to increase uptake, and we're anticipating that will be resolved. Interestingly, bowel screening uptake increased over the pandemic, potentially because people were having more time to undertake the FIT test, which is the test for bowel cancer screening. The breast screening again delayed, and there are some contractual issues that NHSE are working through locally. Some of that is to do with staffing and availability of staffing to work in more remote areas, but that's being taken on by our colleagues and negotiations are ongoing. Retinopathy screening is again on catch-up, as is the 3 areas, which is the abdominal, aortic and aneurysm screening. So from a communicable disease point of view, looking at the numbers of cases of diseases that we are seeing, there are slight increases compared to 2020, but clearly in 2020 there was very little mixing, and therefore we're seeing low cases from that time. We are seeing an increase in mumps, measles, rubella, but it still does remain low in terms of overall cases, so no major concern. We're seeing some increase in chickenpox and Streptococcus A, which is the bacteria which is responsible for tonsillitis, etc., but also for scarlet fever. We're seeing some increase in schools, again, not of concern, but something that we should be monitoring. We are getting messages that our younger children are more vulnerable to infections at the moment because of our isolation. And one of the viruses that you will have probably picked up on the news is the virus which is causing hepatitis, that it's linked to adenovirus, and WHO is investigating, but it's an international phenomenon, the increase in hepatitis in children. Seeing some increase in norovirus, again, nothing of concern. Some increase in flu, and we're seeing it later in the season, but again, not particularly concerned at the moment. COVID cases, we are seeing a decrease, but as you probably know from previous discussions, because the testing is now not in place, it is actually quite difficult to monitor the numbers of COVID cases. But from the data that we have, and there is a national programme of monitoring, but it's through the ONS. What we're seeing comparatively to West Midlands is that Shropshire is the middle top end in the numbers of cases, 290 cases reported last week, 6th of May to 12th of May. But we do know that we are seeing more cases comparatively more in our care homes. So the infection is still out there. Moving on to food and waterborne disease, Campylobacter, we'd expect to see a significant number of cases, and we are seeing that. That's normal. And other food and waterborne diseases, the numbers are low, with the exception of salmonella. Salmonella cases have risen, but not of concern. Just 3 other issues. I will mention monkeypox because it's in the news. Ukrainian refugees are now arriving in Shropshire, which means that there is a risk because not everyone from Ukraine is being vaccinated to the level compared to the UK population. There is a checklist being developed with our NHSE colleagues and local GPs. We'll have that checklist to check vaccination status, and then the individuals be offered additional cover. The locations where there is low childhood vaccine uptake, there was a report last time about health inequality, so that will carry on. The actions linked to that, I think Bernie brought that, and we are in the process of writing a more detailed, based on data that Alex and the team are providing, health protection strategy, which will link in with the COVID strategy and strategies that we've developed previously. Just a few words on monkeypox. You will have seen that there are some cases in the UK. They're usually travel related, but some of the cases that we're seeing are not travel related. Nothing in the West Midlands, so nothing of direct concern. And it is a virus that's related to chickenpox, obviously not chickenpox. It's not easily transmissible, and the transmission that we're seeing tends to be in males who have sexual partnerships with males. So the reason for transmissions isn't quite clear at the moment. And also the distribution, with some cases being in the north of England, some in the south of England, isn't quite clear, but it is something that we're keeping an eye on because we don't want to be in a situation where we'd be surprised. However, even if we do see cases, generally individuals will recover quite well, so it's not a particularly serious infection. But it sounds it from the name. So thank you, Chair.
Thank you very much. Thank you for that. I'll be pleased to know I'm one of your 60% who've taken up the shingles vaccination. Right, are there any comments or anything on that? No? Lovely. Right, so the recommendation is that the board notes the content of the report. Should be noted. Thank you very much. Oh, sorry, did you want to say something?
No, I was just thinking, just to see if the board are happy with the report, we'll ensure that we keep bringing these through so we can keep you updated, because it's obviously an important assurance issue for the board. So thank you.
Thank you. Right, moving on to item 11, which is chairman's updates and close. Right, so from the chair, I'd just like to say this is the first board since the Ockenden review was published on the 30th of March 2022. I know that all our thoughts are with the families who've suffered so much distress and shared their experiences. It is reassuring that many measures and recommendations in the report are already in place to improve services at the Trust, and it is making itself accountable to the parents and families affected to restore public confidence and transform its culture. Our scrutiny process have an important role to play in monitoring outcomes, particularly in the case of our joint health overview and scrutiny committees across Shropshire, Telford and Wrekin, which has responsibilities for scrutinising health services within their areas. In addition, as partners and in chairing the Statutory Health and Wellbeing Board, the board acts to ensure that key leaders from the health and care system work together to improve the health and well-being of Shropshire. And as chair of the board, we make the commitment to continue to work together in this way. Next are the changes to the pharmaceutical list. Has everybody had a copy of those?
There's sorry. The pharmaceutical list is a summary of it, which will go on the website, which details the changes.
That's fine. I don't think I need to go through it. I think in the past
No,
I've gone through it and
it's
it's been a bit tedious.
Yeah, it's generally changes to opening hours, which is actually extended
Yeah.
opening hours, which is a good thing.
Okay. Yeah. So with that, has that information been placed on the council website? The meeting's closed, but members are asked to remain for another short while, while we just need to do some updates. Okay.
Just need to end the land. Can you tell Michelle we can end the meeting?
Oh yes, Michelle, if you can close the public session, then we can come offline. Are we offline?